The title for today's Speaking of Health is
Where my
Diabetes
volume
and
is.
Diabetes, Just a Touch of Sugar. Right now and throughout the presentation, if we could ask all our viewers to be on mute, and if you have any questions, please type your questions in the chat box and our speaker will answer them at the end of our presentation. So at this time, I am honored and privileged to introduce our speaker, Naomi Fukuda, our lead APRN at our Diabetes Management and Education Center located at the Queens West Oahu Physician Office Building. Welcome, Naomi. You may now proceed with your presentation.
I can't hear them.
Can you hear me, Naomi?
Is your sharing?
Yes.
Okay.
Okay.
Now I can hear.
Yeah.
To our audience, just be patient. We should get her presentation up and running momentarily.
Can you guys see the PowerPoint?
Not yet.
Okay, hang on now.
Oh, nothing from PowerPoint.
No.
You share. Okay. Can we X out?
And
Yeah. From share content. Yep. Start.
All right, we see it now, Naomi.
okay, now we got it.
Yes, you may begin. Thank you.
Okay, so hi, I'm Naomi Fukuda. I'm the Diabetes APRN here at Queens West Oahu Diabetes Management Education Center. And I'm here to talk about prediabetes and diabetes, just a touch of sugar. So welcome everybody to my presentation. So first thing we want to discuss is just how common is prediabetes in Hawaii. So in Hawaii, there's about 410,000 people in Hawaii who have prediabetes. So this is about 37.1% of our adult population. So to put it in easier terms, you can imagine 5 people sitting together and 2 out of the 5 have prediabetes. And hopefully you're not one of the 2 out of the 5. And how common is diabetes in Hawaii? So there's 128,653 people in Hawaii. That's about 11.2% of the adult population have diabetes. So this is like if you have 10 people sitting together, 1 out of the 10 has diabetes. And about 39,000 people in Hawaii have diabetes, but they don't know it. And that's the scary part, because we really can't get treatment or know how well your diabetes is controlled unless you know that you're dealing with it. And every year, an estimated 10,041 people in Hawaii are diagnosed with diabetes. So it is a very increasing problem in the state of Hawaii, as well as in other states in the United States. So exactly what happens with food and your blood sugars when you eat. So in a normal person without diabetes, when you eat food, then your stomach breaks the food down to create sugars for the body to use as fuel. And then the sugars get absorbed into your bloodstream. And then your pancreas, which is a organ in your body that produces insulin, the beta cells on the pancreas will release the insulin hormone. And the insulin hormone is what we use to transport the blood sugars out of your bloodstream and into the muscle cells where it's used as food. And this is what your body does on its own if you don't have diabetes. So again, this is another pictorial where you can see that think of insulin as our sugar regulator. And it's sort of like a key that you use to unlock the cell. So then that way, when the cell is open, then that will help to bring the blood sugars in, and then the muscle cells can use that sugar for its food source. And this happens all throughout your whole body, including your brain cells, where it uses the blood sugars as its food. So this is a true or false question. So eating a lot of sweets and sugars when you're young cause you to have prediabetes or diabetes. And this is actually a false um, answer, because the eating a lot of sweets and sugars doesn't cause the prediabetes or diabetes. There's a lot of other factors that can cause you to develop this disease. And we'll go into that a little bit later. So exactly what is prediabetes? So, oops, hang on. So with prediabetes, the pancreas beta cells that produce your insulin are slowly dying off. And exactly why this happens is one of the big questions that our researchers are working on. If we could figure out why your beta cells slowly start dying off, we could actually find a cure for diabetes and prediabetes. But for some reason, the pancreas beta cells slowly start dying off. And so instead of having like 100% of your beta cells working, by the time you have prediabetes, about 50% of your beta cells are already dying or dead. And the beta cells, again, are important for your insulin production. So when your pancreas beta cells are only about 50% functional, then those remaining 50% now have to pick up the workload for the 50% that have passed away. And if this situation doesn't improve, and you continue doing things that's going to enhance the beta cells to slowly die off, then that's where you go into the diabetes range. So think of prediabetes as one step below having diabetes. So when you finally develop diabetes, about 80% of the pancreas beta cells have passed away or died. So that leaves only 20% left to do all the work for the insulin production. So think of it as, the 20% of the beta cells left are actually working overtime 7 days a week, 24 hours a day. And when that happens, they're still expected to produce the same level of insulin that you've been producing in earlier in life. So when you're forced to work overtime so long, then sometimes the quality of the insulin production goes down. So that's where the insulin now being produced by pancreas with diabetes is being produced as defective, or the pancreas beta cells just can't keep up with the production volume that's needed to keep blood sugars under control. So that's where we start seeing blood sugar levels slowly start increasing. So that's the pancreas and the insulin are your basic things that are going wrong when you start developing diabetes. But there was a endocrinologist whose name is Dr. DiFranzo, who further developed his theory as far as what else is going on with diabetes. Because if it was just a problem with not enough insulin or ineffective insulin, then we should be able to control blood sugars really well if we just replace that insulin through our insulin shots. But we all know that just taking straight insulin shots is not always as effective in bringing down blood sugars. So he did a lot of research, and he found that in patients with type 2 diabetes, there was a lot of other defects going on, which would explain why there was patients just taking insulin shots just weren't always having the lower blood sugars occurring. So in this slide, you see there's actually 8 different things going on that was causing blood sugars to be elevated or high. So again, this is the pancreas, and we know this one for many, many years now that the beta cells in the pancreas just not in secreting the insulin that's needed or secreting insulin that doesn't work as well. Then they found that also in the pancreas is another cell called the alpha cell. And they found that people with diabetes were also having a lot more of the alpha cell producing glucagon. So glucagon is another hormone that the body uses. And the way the body uses glucagon is that it actually can help to release sugars from your own body. So your body has the capability of producing sugars on its own if it needs to. So somebody without diabetes, the glucagon is used if in case the body detects that for some reason your blood sugars are dropping too low. So that way the body has a mechanism or safety mechanism to make sure that your blood sugars don't go down too low. But with somebody developing diabetes, for some reason, these pancreas alpha cells become overactive and they start producing more glucagon than what they should be producing. So that's where it helps to keep your blood sugars up higher, which is something we don't want. Then we also knew from quite a while now that the liver is also active in producing glucose by also helping with the glucagon production. So the liver normally is another safety mechanism that to help prevent low sugars in somebody without diabetes. But again, once you start developing diabetes, then that's where your liver goes into overdrive and starts pushing out sugars overnight, especially. So this is where people with diabetes sometimes would test their blood sugar like at bedtime. And when they test their blood sugar at bedtime, it may be like 150. And then they go to sleep. They don't eat any bedtime snacks. They don't wake up for a 3 a.m. snack. They wake up the next morning and your blood sugars have gone from 150 up to like 200 or 210. And they were wondering, well, what happened? Could be that the liver just started overproducing sugars and pushing out sugars when it shouldn't be. And this is one of the core defects that we see in people with diabetes. Dr. DiFranzo also then discovered that in your stomach, in the intestines, there's also another hormone that the stomach releases that's called incretin. So this hormone, as soon as you start eating, this hormone is being released automatically from your stomach. And the incretin hormone then works in conjunction with your insulin that you're getting from your pancreas to help bring down blood sugars. But with somebody with diabetes, that your incretin hormone production from the stomach for some reason is decreased. So that's where we're seeing that's another function of the body that has a defect, which is why just simply replacing somebody's insulin through insulin shots, that's one of the reasons why we don't see blood sugars coming down the way it should be if it was just an insulin defect. Then also in your fatty tissues, when you have the high sugars, it causes your fatty tissues to start breaking down. And when the fatty tissues start breaking down, then that also releases more sugars. The next one that we found is also in the kidneys, because usually the kidneys will release some of the sugars from your bloodstream into your urine at a certain level. But with somebody with diabetes, we found that that level where the sugars from the bloodstream starts leaking out into your urine is actually at a higher level than with somebody without diabetes. So that's another core defect. Then we found that in your muscles, the muscles just don't take up the sugars the way they should. And this is one of the hallmarks of what we call insulin resistance, where your insulin just doesn't work as well. And because it's not working as well, your muscle cells can't take up the sugars out of the bloodstream. So if it's not taking the sugars out of the bloodstream, your sugars are going to stay in the bloodstream, and that's where the blood sugar levels remain high. The eighth defect that he found was in the brain. There's also a dysfunction in the brain occurring with the hormones there. So um, that's where the hunger signals start, and why you always feel like you're always hungry. So that's where there's a hormone imbalance in the brain too. So this is what we call the ominous octet. And the reason why this slide is important is because we have medications that will actually help with each of these core defects, um, that will help to lower the blood sugar. So with the treatment of diabetes nowadays, is we don't just go straight to metformin, or we don't just go straight into insulin injections, because there's a lot of other options out there that we can try, just to kind of tailor the treatment to the individual. And then if you have any questions, then just put the questions in the chat box, yeah? So how do we diagnose prediabetes? We do it through a blood test primarily. So there's a blood test that's called an A1C level, and this is your 3-month average for your blood sugars. So if your A1C level at the lab comes between 5.7 to 6.4, then that's considered as a diagnosis for prediabetes. So anything 5.6 or less is what we consider as normal. Or if you go to the lab and you have a fasting blood sugar level from 100 to 125, then that's considered as prediabetes. Or if you go to the lab and you have a non-fasting where you've been eating and you go for a blood sugar level, any sugar level between 140 to 199 will give you the diagnosis of prediabetes. For the diabetes diagnosis, is your A1C level of 6.5 or higher, or you have a fasting blood sugar level of 126 or higher, or you have a non-fasting blood sugar level of 200 or higher with symptoms. So these symptoms are, you're really thirsty, you're going to the bathroom a lot to urinate, or you're losing a lot of weight really rapidly and you're not trying to do that. Those sort of symptoms with a blood sugar level, non-fasting blood sugar level of 200 or higher, will qualify you as having the diagnosis of diabetes. So is there a way to prevent developing diabetes? So one way of looking at this is looking at what the risk factors for diabetes is. So in a nutshell, the risk factors for diabetes is your age 35 years or older. This is something that was recently changed. It used to be risk factor age 45 years or older, but now this current year, the ADA has actually changed or lowered the age, because we've been noticing that we've been seeing people develop diabetes at a younger and younger age. So if you're age 35 years or older, you're already considered having a risk factor for diabetes. If you have a parent, brother, or sister with diabetes, that's an additional risk factor. Certain ethnicity groups are actually higher risk for having diabetes. So the African American, Hispanic or Latino, the American Indian, Alaska Native, Pacific Islander, or Asian populations. So in Hawaii, Pacific Islander or Asian, that's a huge part of our population. If you already have been diagnosed with having prediabetes, that's already a huge risk factor for going on to developing diabetes within the next 3 to 5 years, if you're not doing something for the prediabetes. If you had a history of gestational diabetes, or have given birth to a baby who weighed over 9 pounds, because any baby who gets delivered with a weight over 9 pounds, chances are in utero, that baby was having a lot of high blood sugars that it was dealing with from the mom. So that's where that person probably had gestational diabetes that just was not detected. So if we have that situation, if you're not currently working on doing something to prevent diabetes, chances are later in life you are going to have develop onto prediabetes and then diabetes. If you're overweight, which is a body mass index of 25 or higher, or in the Asian population, because Asians tend to be, I guess, a little bit different, our body mass index of being overweight is actually from 23 or higher. So our body mass index is lower. Or if you are physically active less than 3 times a week, you have a high risk for diabetes. Some additional risk factors that may increase your risk is if you already have cardiovascular disease that you're dealing with, um, or if you have hypertension, which is a blood pressure that's greater than 130 or 80, or taking medications for hypertension, or if you have cholesterol problems. So this is your HDL or the good cholesterol less than 35, and or having triglyceride levels greater than 250. And this is primarily because with diabetes, it tends to be very strongly correlated with having cardiovascular disease or high blood pressure or cholesterol. So the big question would be, if you have actually underlying diabetes and hasn't been detected yet, if you have any of these 3 chronic diseases. So the way I like to look at these risk factors is putting it into non-modifiable risk factors and modifiable risk factors. So non-modifiable risk factors are risk factors that you can't change. So your age of 35 years or older, that you can't change. Some of us would like to change our age, but your age is going to be your age. And unfortunately, every year, all of us gets older. If you have a parent, brother, or sister with diabetes, you can't change your family history. You can't pick your parents. You can't change who your brother or sister is. Even if you're upset with your brother or sister, you can't change the fact that they are still your brother or sister. So if they have diabetes, that's a non-modifiable risk factor for you. Your ethnicity, you can't change that. That's what you're born with, and that's what the gene pattern you're stuck with. So those are the non-modifiable risk factors that you really have no control over. But the modifiable risk factors are some risk factors that you do have control over and you can change. So if you have prediabetes, there's things that you can do to lower your risk for going on to developing diabetes over the next 3 to 5 years. If you had gestational diabetes or given birth to a baby who weighed over 9 pounds, just knowing the fact that you had the gestational diabetes, you can do things now to prevent going on to developing diabetes later in life. If you're overweight, which is a BMI again of 25 or higher, or in Asians, BMI 23 or higher, there are things you can do to work on the weight so that you can actively work on the weight loss part. Or if you're physically active less than 3 times a week, this is again a risk factor that you can actively work on so that you can prevent from going on to developing the prediabetes or the diabetes. So if you've been diagnosed with prediabetes or had a history of gestational diabetes, what you want to try to do is to make the healthy lifestyle changes. So this is things like, working on the weight loss, trying to lose at least 5% of your baseline weight if your BMI is above that cutoff. Trying to make sure that you do your consistent exercise, because the consistent exercise is going to help with not only the weight loss, but it also helps your muscle cells take in the insulin more effectively and bring down the blood sugars. If you want to learn more about how to work with prediabetes, Queens Medical Center, West Oahu, we do have our diabetes prevention classes. So this is a class series that was developed by the Centers for Disease Control, and it was shown to help decrease the risk for development of diabetes by 58%. So it is a very intensive program, and it's a year-long program. So the first 6 months of this program, we work on a goal of 5% weight loss. And then during the second 6 months of the year, our goal is to maintain that 5% weight loss, or even trying to get more weight loss to occur during the last 6 months of the program. And we also try to do in this class, increasing the physical activity to a goal of 150 minutes per week. So, if you're not very active, we don't expect that you're going to go out there and, run a marathon in a day. We start slowly and then slowly start increasing that physical activity level to a point where we can get you as close as we can to 150 minutes per week. So this would be like 30 minutes 5 times a week. Or if you can't do the 30 minutes at one shot, then it can be even like 10 minutes 3 times a week or 3 times a day. That way you're getting the 30 minutes in a day. And during this diabetes prevention classes, our goal is to try to work with you to improve the diet choices, work with you to figure out, what the proper portion sizes are, to work with you as far as what kind of physical activity you can do, and also monitor the weight on a weekly basis. So this is a very good program, and it actually helps to hold you accountable to make sure that you stay on track. And if you complete the program with that 5% weight loss, then it has been shown to decrease the risk for development of diabetes by 58% over the next 3 years after the class. So the reason why we get so concerned with prediabetes now is because with prediabetes, we can actually reverse prediabetes. So if you can get your A1C level back down into the 5.6 or less range, then we can actually say that you have defeated or gotten rid of prediabetes. But once the diagnosis of diabetes has been made, you will always have diabetes. Because already it has shown that when your blood sugars start creeping up into the diabetes range, it's showing that your pancreas beta cells just no longer have that capability of handling too much of the starches or handling too much of the sugars. And it will increase your blood sugars if you eat too much of those things. There is no cure for diabetes. Our goal is to just have your diabetes well controlled or placed into remission. So there's a lot of ads out there now that says about, reversing your diabetes or curing your diabetes, but again, there is no cure for diabetes, and we really can't reverse diabetes. We can reverse pre-diabetes, but not the diabetes. And the reason why we also get concerned with the control of the diabetes is because if your diabetes is controlled, you actually will decrease tremendously the risk of developing the complications of having uncontrolled diabetes. So a lot of times when people hear the diagnosis of diabetes, they automatically go to, oh, I'm going to get kidney failure. I'm going to be on dialysis. I'm going to lose my feet. I'm going to go blind. I'm going to have, no feeling in my feet. But the thing is that a lot of people don't know is that if you control your diabetes, which means, if you keep your blood sugars in the target range of what we're shooting for, then, chances of you going on to having to need dialysis or having to cut off feet or going blind or losing sensation in your feet are very, very, very low. The problem is that when people don't have the capability or can't control the blood sugars, then that's where all these complications start coming in after years of having blood sugars out of control. So what we say is the foundation for control of diabetes is always going to be your diet and exercise. So like this saying from Hippocrates says, let food be thy medicine and medicine be thy food. Um, we always want to work as much as we can on making sure that you're eating healthy and that you're trying to choose the healthiest options. This doesn't mean that, you can't ever have dessert. I mean, everything in moderation. And it doesn't mean that you can't ever eat at L&L's or you can't ever eat at McDonald's. What I tell my patients is, if you find that you are eating at L&L, take the time to look at the menu and try to choose what you think is the healthiest option off the menu. Or if you're rarely eating out like at L&L and you decide, oh, I want to, really have that chicken katsu. If it's not something that you're doing every day, then, you can splurge and just maybe opt for the mini plate rather than the regular plate, and then try to substitute out like the mac salad with a tossed salad. And then that makes it just a little bit healthier than the regular 2 scoop rice, 1 scoop mac, chicken katsu, and then the katsu sauce. Okay. Exercise is also an important part of your foundation because, as this quote says, if you don't make time for exercise, you probably have to make time for illness. So, in the earlier years, when our grandparents and their parents were working, I mean, we had a lot more physical activity. Nowadays, we jump in the car, we commute to everywhere. We don't walk anywhere unless we absolutely have to. Um, we are on computers most of the times, or we're behind a office desk. So we don't get very much exercise. So that's where now we have to physically we have to remind ourselves to be physically active as much as we can. So again, our goal is at least 30 minutes a day, 5 times a week. But what we've been finding, what some research studies have been finding, is that now what a lot of people do is they think, oh, okay, I go out first thing in the morning, I'll do my 30-minute walk, and then for the rest of the day, they're couch potatoes. And that we find is not good because then you got your exercise, but then for the next 23 hours or 24 hours you're not doing anything. So even though you do your 30 minutes of just straight exercise or straight walking or some sort of exercise, you still need to be trying to be not sedentary and just sitting around. You want to try to at least get up and walk around, like maybe 5 minutes for every hour that you're sitting, because that helps to kind of work your muscles and make sure that you're not just not burning the calories the way you should. Okay. And then if you, after you're working on your diet and exercise, that we find that you're still not getting the blood sugars down, then that's where we start adding medications, just to make sure that the blood sugars don't start slowly climbing. Because the other part you got to remember is that diabetes is considered a progressive disease. How fast it progresses is going to vary from person to person. So sometimes just really watching the diet and exercise may not be enough to keep sugars down, and that's where the medications come in as to help the body. Um, so this is one method of looking at the diet. So this is the My Plate. So this is your standard 9-inch plate, not the 10-inch or 12-inch or the large dinner plates. So the 9-inch plate, so half, ideally, I know this one shows vegetables and fruits, but ideally half of the plate should actually be vegetables. And then 1/4 the plate with your whole grains, which is like your brown rice or your whole wheat toast or whole grain bread. And then 1/4 of the plate with some sort of lean protein. So And the dairy is optional. I mean, in Hawaii, with a lot of our Asian population, we have a lot of lactose intolerant people. So that's where the dairy is optional. You don't have to have the dairy serving there. But it's a good way where you can see portion size wise, this is what your plate should look like. And then the physical activity, again, where I was saying the daily activity, your daily routines, where you're not just always sitting on the couch watching TV, that you're getting up at least every hour just to make sure to break up that sitting routine. And then your scheduled physical activity, where your goal is 150 minutes, 150 minutes a week, which is 30 minutes a day for 5 days a week, or 10 minutes 3 times a day for 5 days a week. And then again, just start where you're comfortable, because everybody's going to be different as far as how their physical activity levels are. And also trying to put into your physical activity routine your resistance exercise. So this is a goal of using like your resistance bands or light weights 2 to 3 times a week. And this is where, again, if you're not used to doing resistance exercise or lightweight training, you want to start slow because you don't want to injure yourself and then take 2 steps backwards. So the resistance exercise or resistance training is important because it helps to tone your muscles. And when you tone your muscles, those muscles will actually take in your insulin more effectively and help to bring down those blood sugars. Um, it doesn't have to be something really expensive to get the equipment. So resistance training can be something as simple as just going out to one of the stores and getting those resistance bands, which is looks like those large rubber bands. And those resistance bands come in different resistance levels. So you can start off at the low level and then slowly work your way up. Or if you don't have money or resources to buy resistance bands, then you can actually just use canned products. I mean, you can take a can like of corn and use that. If it's like a 8 ounce can, then that's like a 1 pound weight, and then you can just use that as your hand weights. So, in conclusion, to learn more about diabetes, I would say you can join our Queen's Diabetes Self-Management and Education classes. We have education classes going on both here at West Oahu as well as at our Punchbowl location. But this one, you will need a referral from your healthcare provider in order to join. Or if you give our office a call, then we can actually try to help get the referral from your healthcare provider if you need us to intervene for you. We can also have you sign up if you have pre-diabetes or have the risk factors for diabetes. We can have you sign up for the diabetes prevention program classes. Our diabetes prevention program classes, I have in person here on the West Oahu campus, or we also have virtual diabetes prevention program classes being offered. I'm trying to start our latest cohort group for the virtual diabetes prevention program um, by the beginning of next week. So if you're interested in it, let me know right away, because once I start a cohort group, I want to try to keep everybody together. Then again, if you want to sign up for either the diabetes prevention program classes or the diabetes self-management education classes, you can call the Queen's referral line at that number on the screen, and then they will direct you to the right campus. Okay. And mahalo for joining us. Any questions?
Right. Thank you so much, Naomi. What a great presentation that you have. And thank you for providing information about the diabetes prevention classes. I actually participated in those classes in the past, or actually one of the classes, and it was actually very effective. I mean, it worked, and it was actually very fun. So I would highly encourage everybody that to participate in that if they think they could benefit from that class. But again, thank you. So right now, let's go and proceed with the Q&A portion of the lecture here. Let me see the questions that came on. We do have a question from Doreen, and her question is, if we are already watching our diet, weight, and get the 150 plus minutes of exercise through 3 times a week group exercise, is medication then recommended for prediabetes?
With prediabetes, the main focus that we try to do is trying to maintain or get the weight loss. So if you met the 5% weight loss from your baseline, then the next goal is to get 7%, and then the next goal after that will be 9%, until you finally get into your ideal body mass index. If you're not dealing with a weight issue and you're doing your exercise and you're watching the food and you're still seeing high A1Cs in the prediabetes range, then the next step is usually trying to add in the metformin, just to kind of quiet down the liver. Yeah.
Thank you. Next question is, what is your take on sugar substitute?
Sugar substitutes, what I tell my patients is, given the choice between having regular sugar or a sugar substitute like Truvia or Stevia or Splenda, I tell them choose the Stevia or the Splenda, because at least if you use those things, it's not going to increase your sugars as fast as the regular sugar or the honey or the brown sugar, because any of those types of regular sugar guaranteed is going to increase your blood sugar. I wouldn't suggest, eating or using like 10 packets of stevia in your coffee, or trying to use like 20 packets of Splenda in a day, because then you're just taking in too much of the sugar substitutes. Because there's been some research that's been showing that, having too much of sugar substitutes can actually have some adverse reactions. So I would say, try to use the sugar substitutes just to kind of sweeten things so that it doesn't taste as bland, but try not to go overboard on using it, because then you may actually start training your taste buds to be looking for more and more sweets, and that's not going to be a good thing.
Thank you. Next question is, what is your thoughts about the trend that people are using diabetes injectable drugs to lose weight? What are the risks?
The risk for that is, first of all, they're affecting the supply for patients who have diabetes who need those medications. The second thing is that there are similar medications out there that have been designated for weight loss. So they need to, as much as possible, they really should be using the medications that have been approved by the FDA for weight loss, and they wouldn't qualify for the diabetes medications. The big problem with using the weight loss medications or diabetes medications for weight loss is now we're coming to a point where we're asking, how long do these people stay on it? Because, if they lose the weight and then all of a sudden we just take them off of these medications, most times we will see weight coming back on. So a lot of times people use these medications as a quick fix. They're thinking, oh, I'll just take this. It decreases my appetite and weight comes off, and I don't have to do anything else. So the one thing that they have to remember is that anytime you're using weight loss medications or diabetes medications that help with weight loss, is you also have to also make sure that you're also incorporating into that is you're making good food choices, and that you're trying to also stick with the exercise, because those are the two things that are going to keep the weight off once we start trying to decrease those medications.
Very good. Thank you, Naomi. There's also a question here regarding Is it Farxiga? And the question is Farxiga bad for initial prediabetes assessment?
Well, Farxiga has not been approved for use in prediabetes. Farxiga it's a medication that we use that pushes the sugars out through the kidneys. So it started as a diabetes medication that we use to help improve blood sugars. Um, but now we've also been seeing that it also helps to uh, protect the kidney from kidney damage from either the diabetes or from just other things like high blood pressure. And we also seen that Farxiga actually helps to protect the heart from heart failure. So it has not been really studied in people with prediabetes. So if you're using it for just to treat the prediabetes, then it's actually being used as off-label use.
Next question. When is the next virtual group for prediabetes?
The next virtual cohort group that I'll be starting is I'm trying to launch them by the beginning of next week. So
Oh,
if you're interested, make sure you get your information over to us at our Diabetes West Oahu Center, so then we can make sure that you get started with this cohort group.
when is the next one after that?
Next one after that is probably going to be like in 4 or 5 months.
Thank you. Next question. How strenuous does the 150 minutes of exercise have to be in order to be effective?
That's going to be based on the individual. So if you're not used to exercising, going for just a slow walk, as long as you know you start feeling like you're a little bit of short of breath or you feel like your heart is going up a little bit, then that's a good level for you. If you're used to exercising, then you know you can walk at a faster pace. So it just depends on the individual and how their endurance levels are.
Thank you. Great questions. Please keep those questions coming in. The next question that we have is, what is the viewpoint on natural sugars like maple syrup, agave, and honey? So earlier we talked about sugar substitute. Now they want to know more about these natural sugars, maple sugar, agave, and honey.
Uh, Natural sugars like the maple syrup and honey are still sugars. So it's still going to increase your blood sugar level if you use them. Agave is a natural sugar from the agave plant, which is what they also use to make tequila out of. Um, Now, the reason why agave is a little bit different is that because it's super, super sweet, you use a lot less theoretically. So if you use a lot less, then you can use that and it won't drive up your sugars as much. But the key word is using less of the agave and not using it to make something super, super sweet, because then, yeah, your sugars are going to go up.
Very good. Are there any more questions? Yes, there's one more here. Is it safer to start with uh, metformin versus Farxiga for prediabetes where there are no heart, kidney, or weight issues?
Again, Farxiga is not approved by the FDA for treatment of prediabetes. So that would be a definite off-label use. We haven't really studied or have seen it used in the prediabetes group. Metformin, unfortunately, too, does not have the FDA approval for prediabetes use, but we have been using it a lot in people with prediabetes, including the Centers for Disease Control, when they ran this diabetes prevention program. They had actually 3 cohort groups running just to see how effective certain treatments were. So they found that they had one cohort group, which was a standard cohort group, which got standard treatment. And then they had a second cohort group where they were going through this intensive prediabetes program that we offer. And then they had the third group, which is the group that they just gave metformin to because they had the prediabetes. They found that the standard group didn't do too well. The intensive lifestyle changes from the prediabetes program did the best, and then the metformin group did the second best. So that's why we use metformin, even though it does not officially have the FDA approval. It's because we've been using it for a while in different scenarios, and we found that it has been effective.
Thank you. This may be the last question, unless we have more coming in. And that question is, isn't salt a culprit also for diabetes?
Salt is not a part of diabetes because the salt is more effective or it more affects like the blood pressure. And that's where maybe there's like a tangent thing to diabetes, but if you have taken too much salt, then that's where that increases your blood pressure. And if you're taking too much salt, that might increase your risk for eventually developing things like heart failure. But all of those diseases, if you have them, that they can actually cause or be associated with diabetes. But just having too much salt doesn't increase your risk for developing diabetes.
Very good. And I think that really is the last question. Or actually, we have one more that just came in. Can autoimmune disease impact prediabetes, specifically Hashimoto thyroiditis?
The autoimmune diseases, might cause you develop diabetes. Again, we don't really know what causes diabetes. We do see some people with diabetes who have some autoimmune impacts. That's where they start developing like a form of type 1 diabetes. And that's if you have that certain form of type 1 diabetes, it is an autoimmune cause. And that's where if you find that you have a type of autoimmune disease, that's where maybe you want to be a little bit more cautious and make sure that your body doesn't develop other types of autoimmune diseases.
Thank you, Naomi. Next question, which is worse for prediabetes, carbs or sugar? Or there any difference between the two?
Sugar is actually a form of a carb. So you actually want to kind of control both. Yeah. So the problem is that if you take in a lot of sugar, it's going to cause your blood sugars to spike higher faster. If you take in a carb, then the sugars may not spike as fast, depending on what type of carb you take in. Um, so it's more a matter of looking at how much total carbs you take in, as well as trying to not take in a product that is like say total carbs is like 20 grams and the total sugars in that particular product is 20 grams of sugar, because then that's just all straight carbs that are straight sugar.
Okay. And this may be the last question. If a diabetes medication has not changed the A1C level in 5 months, do you recommend changing to another medication?
I think it would depend on the individual. That's why being referred to our diabetes center is helpful, because we actually, that's all we kind of focus on is diabetes, versus the primary care physician has to juggle a lot of other chronic diseases at the same time in the same appointment. But at the diabetes center, if we don't see an improvement in A1C in that time frame, then yeah, we are looking at, can we go higher on this medication? Or do we need to add in another drug class for this regimen? Or, is there room still for improvement in the food choices, or is there room for improvement on the exercise?
All right, yeah, that was our last question. Really great questions, everyone. Thank you so much. And again, I'd like to thank once again our speaker, APRN Naomi Fukuda in our West Oahu Diabetes Management and Education Center. We'd also like to thank all of our virtual audience for joining us today. And that concludes our Speaking of Health presentation for May. At this time, we'd like to ask all of you, our virtual audience, to please complete the evaluation. Information is on your screen. Simply scan the QR code on your screen using your smartphone or complete the evaluation by clicking the URL in the chat box.
Okay, thank you.
Okay, so again, the Queen's West Oahu Virtual Speaking of Health Lecture Series is the third Thursday of each month at 12 noon to 1 p.m. Please join us for the next lecture, which is scheduled for Thursday, June 15th. And our speaker will be orthopedic surgeon Dr. Edward Chan, our hand and upper extremity specialist here at the Queen's Medical Center West Oahu. And the title of his presentation will be Getting the Upper Hand on Carpal Tunnel Syndrome. So look out for the announcements, which will include the registration information. We hope to see you then, and feel free to share or forward information to your friends, family, colleagues, and anyone you think may be interested. On behalf of our Vice President of Operation, Robin Kaluhilani, our Chief Medical Officer, Dr. Ronald Kuroda, and the entire Queen's Medical Center West Oahu Ohana, mahalo nui loa. Thank you very much for joining us today. Until next time, please take care and always be safe. Aloha.